I'm Barbara Morris. I'm thrilled to be here with all of you. I came from Denver last night. Only Vail Pass was challenging, so happy to be here. It's a gorgeous day. I had time for a walk in one of your state parks this morning. I always tell people that I can tell a lot about a community by their parks and their libraries. So you hit a home run here in Grand Junction, because for my short visit so far, you have beautiful community and state parks and a beautiful library. So thanks for hosting us. I just want to introduce and thank a few people. Anna Olivas, who some of you have met, is one of our volunteers from End of Life Options Colorado. As I said, she's the bringer of all good things, so please enjoy. She's going to be helping facilitate our panel in a little bit. And then I want to give a special shout out to those people from Hope West Hospice who are here with us, who've helped spread the word, and also Ellen and Jerry, who have been hostess and all things incredible, including finding some people at the last minute to do a recording for us that we can share for those folks who couldn't be with us. So thank you so much. Yes, we appreciate it. A few logistics with Jerry reminding me of, please put your cell phones on silent or turn them off. We are going to be kind of informal, but we will have plenty of time for questions towards the end. And the structure for this afternoon is going to be that I'm going to be giving a conversation about options at the end of life with a special focus on medical aid and dying. And then after that, we're going to have a community, what we call a community conversation. And that's going to be time for us to collect your questions, kind of get different categories, and hear from folks in your community about what some of the issues are and try to answer some of your questions. I would like to keep this a little bit informal, so if you do have a burning question in the middle of one of my slides, let me know if a question of clarity, or if I said something that sounds really strange to you. Fine with me if you just put up your hand and interrupt. Otherwise, for some of the bigger topics, we'll keep that for the community conversation. Does that sound good? Geriatrician, I recently retired from ambulatory practice at a community health center in Metro Denver. I still have a small consulting practice, and it's that vehicle that allows me to continue to help some patients and their families with particularly issues of geriatric advocacy and also end-of-life care, including medical aid in dying if patients' own care team can't provide that. My husband and I love to travel. That's us in Argentina almost a year ago. It's hard to believe. And then we also are very lucky to have a home in Costa Rica, and that's our whole family with my 3 grandsons who are a little bit rambunctious, my daughter and my husband in Costa Rica. I want to make one comment here about the presentation today and the topic. Some of you will be aware, even though Denver seems far from here, that some years ago I got into a little bit of a tussle with my employer around an issue of a patient who was requesting medical aid and dying, and that resulted in some unpleasantness, to say the least, and some legal proceedings that are still underway. And so for those of you who know about that or want to know more about it, that is not today's topic. And I just want you to know that. I see someone laughing in the front row. But seriously, it was a very difficult time for myself and for the patient. And it raised a lot of the issues we're going to talk about. If you are interested in what happened with that particular situation, I'm happy to chat with you privately about it. Or you can Google it and read what you want about it. But I just wanted you to know that that's not why I'm here today. It's kind of a separate issue. All right, so just as a reminder, End of Life Options Colorado, a new organization we incorporated just over a year ago. We kind of see ourselves as sisters to organizations you may have heard about: End of Life Options New York, End of Life Choices California, Oregon, Washington, New Mexico, Hawaii. Almost all states that are involved in medical aid and dying have their own organization. And about a year and a half ago, we realized that Colorado really needed our own organization. And so our purpose is, part of why I'm here today, our purpose is to make sure that all Coloradans have education and access, a very important piece of this, to their choices at the end of life, with a special emphasis on medical aid in dying. So that's what we're going to talk about. What are your options at the end of life? All of our options. I want you to be able to understand our state statute because there's a lot of myth and misinformation about the statute. And then we'll talk, oh, I didn't change my slide, I apologize. I thought I caught on this. We were in Durango a few weeks ago. We're going to talk about resources in Grand Junction. So let's remember this. When my husband and I were in Argentina last year, we took a tour and we were going through this museum with a guide who we had never met before. He knew nothing about my background. Actually, he didn't really care. And we were standing in this museum, and all of a sudden he said to me, "Oh, you need to look at this statue." I thought, how did he know? He happened, as it turned out, to have great interest in death and dying and all the rituals from ancient times. I add this slide because I'd like us all to take a deep breath and remember that we are struggling with these issues about end of life. But we need to remember, of course, that humans have been struggling with end-of-life issues for a very long time. And I suspect we will continue to struggle. Also, I want us to keep in mind, and this is very, very important, medical aid in dying is a tool, is the way I look at it. But it's not the only tool that we have in the end-of-life toolbox. So those of you who are in particular are palliative or hospice professionals will know what I'm speaking of. We have many tools to help at the end of life, and medical aid in dying is one of them. It's the one we're going to focus on today, but it is not the only way to have a dignified death. And we also need to remember that not all patients, this is very important, who go through the process that I'm going to describe and qualify for medical aid in dying, not all of those patients will make use of the medication. In fact, about 30% of patients will not end up making use of the medication. And there's a lot of reasons for that, but what we hear from patients and families is the incredible relief and decrease in anxiety patients feel if they know that they have that option and that their wishes will be respected. And during a very terrible time in terminal illness, that they will be able to be back in control of their situation. So it's a very important thing. I'm going to highlight this word dignified for just a minute. You know, some states, their act is actually called Death with Dignity. We have a Death with Dignity national organization. That phrase has been used a lot as code word for medical aid in dying. And recently, some of us have realized that we need to be cautious about that. Because the implication has become, well, if I don't use medical aid in dying, does that mean I can't have a dignified death? And at least in my personal opinion, that's something we have to be very cautious about. There are many, many options at the end of life, and many of them are also very dignified and very peaceful. So I want you to know that, because as we go through this, and I'm sure some of you have the questions you're already writing down, well, what about this, what about that? Not everybody can qualify for medical aid in dying, and I don't want anyone facing terrible illness to feel like they're missing out or losing in some way if they can't use medical aid in dying. So I hope that makes sense. It's really an important issue. All right, so I'm going to go over this relatively quickly. I suspect that we have a lot of very well-informed people here, but just as a reminder, in the United States, we have multiple options at the end of life. Continuing standard medical treatments, stopping or declining treatments. Those are things like saying, I don't want an attempted resuscitation if my heart stops, I don't want a ventilator, I don't want a feeding tube. If those things have been started, we have the right to stop those things. Palliative care, which allows patients to have a symptom-based approach to their care while still undergoing what we would think of as more aggressive treatments like chemotherapy and radiation therapy and surgical approaches. I know we have some hospice folks here and some hospice volunteers, and thank you for your work. Hospice is an approach that turns towards comfort care and really taking care of symptoms and addressing what patients want in their final days. And there are a lot of issues with hospice and medical aid and dying, and we'll get to that in a little bit. You know, someone wrote this list and added natural death. And I left it on here because I thought, that's kind of an odd phrase. I think that's this implication that someone decides that they're not going to have any particular interventions in the course of their illness. No particular medications, no surgeries, no chemotherapy, and so forth. Palliative sedation is one you may or may not have heard of. The hospice folks probably are familiar with palliative sedation. You know, we pride ourselves in hospice and palliative care on saying that we can control symptoms. Like, that's what we say. We're going to control your symptoms. We're going to control your pain and your anxiety and your shortness of breath. There are certain unusual situations in which those symptoms actually are extraordinarily difficult to control, and the suffering is really unbearable. And in those rare circumstances, medication can be used, which causes a lot of sedation, but helps with those terrible symptoms towards the end of life. Voluntary stopping of eating and drinking is on here as a separate category. Some of you may have heard of this recently. There's been a lot more press about VSED. In a way, it's really the same as stopping or reducing life-sustaining medical treatments, except we don't really think of food and water as a medical treatment. So in the United States, we all have the right to say, we're not going to eat or drink anymore. It's not really a medical procedure, and we have the right to do that, and if we do, that might result in our death if we carry it through. VSED is something that can be, it is very effective. It's also very difficult both for family and for the patient, because depending on the status at the time of starting, it can take 7 to 14 days for death to occur, which is a long time. And then medical aid and dying in some jurisdictions in the United States. All right, you may be familiar with this map. This is courtesy of a group called the Completed Life Initiative. So we have multiple jurisdictions. Colorado is one of them. New Mexico is one of our most recent states. Of course, you all know about Oregon, which was the pioneer in this, actually now decades ago. Hawaii as well. And in many states, we now have laws that are either in process and variations on a theme to make medical aid and dying more available in other locations. All right, so we're going to turn towards our statute. Just as a reminder, in Colorado, the End-of-Life Options Act was passed in 2016. Some of you may remember that. Some of you might have been working on it. The act went into effect in 2017. And so that's now been quite a while ago, and we've been looking a lot at what's happened since then. And what we've realized, of course, is that we have the law, but we have a lot of work to do. Sessions like this, thank you for being here, to make sure that people understand their choices and what the law is about. Not only the lay public, but also our professionals, our physicians in particular. So I'm going to go over this in quite a bit of detail because I want people to understand what our law is. So as with most states, you have to be 18 or over. You have to be terminally ill with an expected prognosis of less than 6 months. You have to have decisional capacity. You have to be able to self-administer the medication. And you have to be a resident of Colorado. And you may have heard more about this in the news lately with the lawsuits on the East Coast and the West Coast. And some of those residency restrictions have been shut down by the courts, and we don't know what will happen in Colorado, but that might change. A couple of things that are important to focus on. What is decisional capacity? It's an important one. So this is not competence that the courts decide. Decisional capacity is a medically related capacity, so that the clinician involved, in this case physicians, have to make sure that the patient has the ability to understand the decision at hand, to understand what the choices are, to understand the consequences of that decision. So this gets very important because we have many patients facing terminal illness and end of life who may have some memory challenges, but who are clearly capable and have decisional capacity over this decision. And so that's an important one to remember. The self-administer one we're going to talk more about in just a minute, but it basically means that the patient has to be able to take the medication by some route, not necessarily oral by themselves. There are a lot of qualifications included in the law, and when I talk with patients and families about this, I say, look, you know, this sounds overwhelming. What I'm about to tell you seems like a lot, but we can get through this. But we just got to stick with it, and we do have to follow the law. The law was written in such a way as to protect patients and families and physicians. And I'll tell you, in doing this work, that it sometimes gets a little bit aggravating, but we can get through this. That's what I want you to know. So patients have to make the request not once, not twice, but 3 times. Seems like a lot. So two of the requests are oral. You have to talk with your physician and say, this is what I want, this is why I want it. You have to show decisional capacity. You have to have a terminal diagnosis with a 6-month prognosis. And the physician has to document all that. Currently in our state, no earlier than the 15th day, the second verbal request has to be taken. Same content, actually. What's your diagnosis? Do you understand it? Do you have decisional capacity, etc.? That's on the 15th day. In between that time, or sometime, there has to be a written request which is witnessed, which basically says the same thing I just talked about. And then there has to be an evaluation by a consulting physician sometime during this period of time. And the consulting physician has to confirm the diagnosis, confirm the prognosis, confirm that the patient has decisional capacity, and write a letter to the attending physician to say, I agree with you. So these are all requirements of the law. And we'll talk in a little bit about the difference between the law and best practice in medical aid and dying. But these are things that are on the checklist that have to be accomplished. I think there's been some confusion about who can do these steps in terms of the physician and care team part. In our state, this is different in New Mexico and Hawaii, in our state at present, and this may change, only physicians can do taking the first request, the second request, the consulting, and the prescribing. There are other states where nurse practitioners and physician assistants can do this work, but currently in Colorado, it's only physicians. However, there's been some confusion about whether it has to be your own personal physician or your own specialist who does that work, and that is not true. It has to be a Colorado licensed physician who has the background and the experience to do the work, but I think there's been a lot of anxiety for patients and their families as to, like, my doctor won't do it, so what am I going to do? I'm up a creek. Not so. We can find you help. You know, my personal opinion is if your own care team who knows you is able and willing to help you, to me that's what makes sense. You know, you should be taken care of by your own team. Unfortunately, that's not always the case, and so we want to make sure that patients and their families know that there are other choices in Colorado. It does not have to be the team that's been taking care of you through the course of your illness. Although, again, wouldn't that be wonderful if they would? All right, and then just some emphasis here. You know, this is the patient's decision, and we emphasize that throughout the whole course. First request, second request, we always end by saying, you understand that no one is coercing you. You can change your mind up until the moment that you take a first sip of the medication. And so that's very important for everyone to understand. And also there are a lot of questions about death certificates. And our law, and I think all states, you know, what we have to remember when we talk about this is that what is causing the death of the patient in this circumstance is their illness, their terminal illness. And so that's the diagnosis that goes on the death certificate. So medical aid in dying is not on the death certificate. And that's an important thing for everybody to remember. We get a lot of questions about that. We get questions about that from medical examiners. All right, I don't want to belabor this, but a few things about what I think of as the fine print. Some of it's kind of obvious, age and decisional capacity we've talked about. I want to spend a minute on terminal illness and prognosis. When I was in training, which was a long time ago, I would have thought, wow, that's pretty easy. Terminal illness, prognosis, we're doctors, we should be able to tell you that. Well, I've learned the hard way that there is nothing in medicine that is quite so straightforward. And this is where the art and science come together. I think there are certain situations, many of which you might think of, someone with a horrible metastatic cancer who has failed all therapies, where we really have a pretty good understanding of the time course. But we have a lot of other situations where I'm just going to lay it out there and say we just aren't as good as we think we are at predicting prognosis. I see some heads nodding. And for the hospice folks here, or those of you who have had family members in hospice, you may be aware of the data that tells us that once patients get admitted to home hospice and things are sort of calmed down, that they actually live longer than we would expect. I see some smiles. And that has a lot to do with not going back to the hospital, not having all sorts of tests, not having their life be totally up and down. And so this notion of prognosis is one we're all working on, and I'm here to tell you that all we can do is do our best and have our best understanding based on illness and the other parameters of a patient's health and the rest of the situation to do our best estimation on prognosis. So you know that there are many patients that end up in hospice care longer than 6 months. And as far as I'm concerned, that's great because they're getting great care. And for medical aid in dying, our statute is quite interesting. We have to, as a doctor, I have to say, yep, terminal illness, my best estimate is the prognosis is less than 6 months. I might be able to write the prescription at that point. And a patient might plateau or even do a little bit better and still be around many months after the 6-month mark. The statute actually doesn't say I have to redo all the work to move ahead with the patient. So it just kind of makes for some interesting thinking and philosophical thinking. We can talk more about that during the conversation. All right, we've talked about the 3 times, we've talked about the prognosis, and again, this is where art and science come together. So at this point, in theory, the attending physician can write the prescription. And I think in the past, I don't know if anybody was around in the days that people were using a medication called secobarbital. It's a barbiturate. Someone's nodding. I've never had to prescribe it, and now we can't get it. But at that time, people would kind of write the prescription and say, "Okay, here, see ya." I don't practice that way, and I don't think most of my colleagues practice that way anymore. So what happens, at least in my practice, if we get this far, when we get this far with a patient and a family, I stay in very close touch and work with the patient and family to decide when the day of ingestion is going to be, what that's going to be like, who's going to be there, hospice being involved. So in a lot of ways, the real work begins once we get through this whole checklist. It's a checklist we have to do, but we have to keep caring for the patient. And I would say that most of my colleagues in Colorado are no longer writing the prescription or sending the prescription on the computer until we know that a day of ingestion has been chosen. For many reasons. We don't want these drugs hanging around in anybody's home. These are lethal drugs. We don't want them just hanging around, and they become more and more expensive. And so we don't want people spending that kind of money if the drugs aren't going to be used or any potential for drugs expiring. So evidence-based practice is what I call this. This is where everything comes together. And I can only speak for myself and some of my closest colleagues as to how we do this. I can't tell you it's how everybody does it, but I think it's a model that's really important. So patient assessment, which has to include the whole picture. Determination, I think it's important here. We can meet the checklist, but medical aid in dying might still not be appropriate for that situation. And so we have to put all the pieces together. Hospice enrollment, in my opinion, is an absolute necessity. The law says nothing about hospice enrollment, by the way. However, for all the reasons that many of you know, having terminally ill patients facing end of life have the support and care of hospice, in my opinion, is critical. It's critical for the patient, it's critical for the family, and in the end, it really helps during the time of death at the end. Pharmacology recommendations are very important. We work very closely with our pharmacist. And then ongoing assessments until the day of ingestion. And we've talked about this already, of staying in touch. What I will do with patients, now I have a few patients at the moment who've done the whole check mark, but they're not ready. And so we speak every few weeks. How are things going? What are you thinking about? When are you thinking about taking the medication? And importantly, to make sure that nothing medical has changed that will interfere with the ability to use medical aid in dying. We call that the red flags. It sounds strange to say that we're worried about safety when we're about to give someone a lethal drug, right? You'd be like, why should we worry about safety? Well, we use the word safety in the sense that we don't want something to go south, right? We don't want a partial ingestion. We don't want someone not being able to get the medicine in. And so there are things we can do to make sure that everything's going to be as smooth as possible. So that's really critical. And then collaboration, ongoing collaboration with all the members of the care team is really important. I don't want to get too graphic with this, so I didn't bring any pictures. Originally I think medical aid in dying was all oral. You drank the nasty stuff. Some people use a little sorbet as a chaser. And that was really considered to be the only way to use medical aid in dying. In the past few years, that's been opened up so that now can be oral. It can be with a tube in the stomach if the gastrointestinal tract is working, or it can be by a rectal catheter. And again, I won't get too graphic, but it sounds, when patients hear that, they're like, ugh. It actually turns out that if necessary, using a rectal catheter can go very smoothly, and death is sometimes even faster than when medication's administered orally. The lining of the rectum, if the GI, that part of the GI tract is working, absorbs medication really quickly, and so it can be very peaceful and very quick. People always want to know about the drugs. These numbers should mean nothing to you unless you're a pharmacist or a clinician in the audience. But just to say that these are ginormous doses of these drugs. And the reason there are actually 5 of them now, phenobarbital was added recently, is that these work on different parts of your physiology. So it works on your brain and your heart and your respiration. And that's why it's extremely effective. Again, these are huge doses, and so if a patient is taking oral medication and there's a little bit of spill or a little bit of vomiting, we don't get too worried about that as long as it's not the entire dose. I see some heads nodding like, I can't believe it. Are you a medical person, or? Okay, so you're looking at these doses and going, no, I can't believe it.
I'm just looking at what is the volume?
Okay, thank you. Good question. I could just see her looking at this like, what? So these are, it's in powder form and then it gets mixed. And so it's in a solution that's kind of like, probably like an Ensure, if any of you have had one of those, or a Boost. So it's kind of thick. It does have a bitter taste. We were using 4 ounces, which most patients could get down pretty well, but was a little challenging. The past 2 years, we've now switched to 2 ounces. So that's pretty doable for most patients to get the 2 ounces down, and we ask patients to get that down within 2 minutes. The reason being that these drugs act really quickly, and we don't want people falling asleep. Sounds funny, but we don't want people falling asleep partway through their dose, because we need to get the dose in. Self-administration we've talked about. I just want to clarify, because there's lots of questions about this, which is, what does self-administration mean? It means the patient has to hold the cup or the tube. For the rectal tube, they hold a syringe and have to show that they're self-administering. But family or hospice staff, depending on the hospice, or doulas, we'll hear more about doulas in a little bit, can assist in the sense of holding the cup, holding the straw, holding the syringe on the rectal catheter. So it doesn't mean that the whole team walks away and says, okay, go to it, you're on your own. It's not like that at all. I really encourage families, patients, and care team to really think about the day of ingestion carefully and with some thought. I mean, one of the things about medical aid in dying is that it gives us control over the situation. And I think most families and patients find this to be very important. So these are the issues of who's going to be there, where is it going to be? Is it going to be oral? What's going to be the method? Is the physician going to be there? Is a doula going to be there? What is the local hospice policy on how much hospice can or can't do? What's going to happen after the patient dies? Very important issues. Hopefully most of those have been gone over with hospice. And then for the clinical part, we do spend some time just going back over this list that we have about, has something changed that means that this is not a good idea? And that's really hard. I've only had that happen once so far, where a patient had qualified, deeply wanted to use medical aid in dying. She then decided she wanted to make another milestone birthday. She and her family knew she was changing clinically quite a bit, and she got to the point, her disease progressed rather rapidly, and she became unable to really make decisions or carry them out. It was really devastating for the husband when I went to see her, and he said, "This is what she wants. We have to let her do this or do it for her." And I said, I understand all that, but this is the kind of situation in which we cannot do this. We can no longer do this. But we can help her to have a peaceful death at home and achieve, most of what her goals were. So that doesn't happen very often, but when it does happen, the care team really has to provide a lot of support, particularly for the family. This particular husband felt devastated because he felt like he wasn't able to carry out his wife's wishes. I think hopefully we helped him to understand why we couldn't do that and what we could do to make sure that she was really comfortable and at home. So a very important issue. And this sounds funny. I think a lot of you are pretty experienced in this audience, but we have had situations where, I don't know how it slipped through the crack, but where the funeral home hadn't been contacted ahead of time, where there were no plans for post-death planning. And so just as a reminder, if you haven't done those things, even if you don't have a terminal illness, it's a good idea to do some of this planning ahead of time. Like, what are your thoughts about the kind of after-death care that you want? We don't really want to get to the day of ingestion and have that information, not be available. So then on the aid and dying day, the day of ingestion, again, making sure that these plans have been carried out. I always tell patients, of course, that they can change their mind until the moment they start the ingestion. And I also always recommend that patients and families say whatever their last thoughts or words are before the ingestion starts, because sleep is very, very quick. And so once the ingestion starts, there's not much time. Of course, making sure the patient's comfortable. And then, death, I'm going to ask you to take a pause for a second. Think back to high school math. I don't know, maybe it's middle school. My grandson seems to be learning algebra in 4th grade. But anyway, sometime you learned about averages, sometime in school. And I want you to think about what an average is, right? So there's a big spectrum. And so we tell patients and their families with the new formula, with the 2 ounces, that average time to death is less than 2 hours. Okay? So what does that really mean, though, if you think about averages? It means we have some patients who die literally within minutes. I think my quickest was maybe 5 or 6 minutes. And my longest, most recently, was 9 hours. That's a pretty big span. And it's quite unusual now to go that long. But I like people to understand that. So if someone tells you, oh, it'll be 2 hours, you're thinking, wait a minute, Morris said maybe 2 hours. And the reason that's important is the patient is going to be deeply asleep and unaware. But the people at the bedside need to have some understanding and some preparation. I believe that to be incredibly important. So for the patient I had with the prolonged death, I knew there were reasons why it might be that situation, And I was able to prepare the family and the friends to take turns, to think about what they were going to do in the middle of the night if this occurred, and to understand that do amazing work throughout, but at the time of death in particular, to make sure that everything is smooth, death is pronounced, the coroner is called, the coroner usually releases the situation, and then the hospice nurse helps the family with calling the funeral home and making the final arrangements. And of course, helping with grief afterwards is really important. And so that part of the process is pretty much the same, I guess, as what happens in a non-medically dying death. The death certificate, as I mentioned, will not mention medically dying. It will be whatever the terminal diagnosis for the patient was. I think we've talked about most of this. One of the things about hospice that some of you are aware of is because of the state law, this has nothing to do with medically dying, if there's an in-home death with hospice, the process I just talked about stands. So the hospice nurse calls the coroner, things are usually very smooth. If there's a death at home without a hospice organization involved, then guess what? Then you have to call law enforcement, and it's sometimes quite unpleasant, and it's one of the big reasons why we want to make sure that all of these patients are in the care of hospice. Many people are interested in the issue about cost. You may be aware that Medicare and commercial insurances, because they follow Medicare, do not pay for medical aid in dying, either for the physician services or for the medication. We can talk during the conversation about why that is. It's related to a statute from the 1990s in which there's a federal act that prohibits any federal dollars going towards what in that act is called assisted suicide. Lots of conversation about that, lots of policy issues with hospices. Our act in Colorado actually specifically says that medical aid in dying is not assisted suicide, but the legal interpretations have been very broad. And if you hear things like the hospice won't participate, part of it is because of their worries about being sanctioned due to that law. We're starting to see some change with that and some better understanding of policies. It's a topic for another conversation, but we can chat more if you're interested in that issue. In Colorado, believe it or not, our medication prices are far-ranging. They started in the $200 and $300 range, and now, at least the pharmacy that I use the most in Metro Denver is up to over $900. So it's an issue, and we work with patients and their families on what's going to be the best situation pharmacy-wise for them. And I am proud to say that as the result of a fundraising effort late this fall for End of Life Options Colorado, we now have a patient assistance fund, which we created specifically because of the medication issue, so that we don't want patients who are appropriate far along in the process to not be able to get medications because of cost. So we feel very good about that and are thankful to our donors for helping with that. Physicians are funny people about money, We think we love it, but really we don't. We don't like talking about it anyway. I was an employed physician for my entire career, so having to talk to patients about fees is like hard to come out of my mouth. I would say that in Colorado we have an array of fee structures with physicians. So some of us charge by the hour. Some physicians have like it sounds funny, a package rate for death and dying, but kind of a package rate. There are a few physicians who are working in health systems where they're using their billing by using things like advanced care planning and other coding so that they're not charging as much on the physician fee schedule side of things. But officially at the moment, these services are not covered by Medicare, Medicaid, or commercial insurance. Oh, and I didn't change that slide either, I apologize. So I want to talk briefly before we get to the community conversation about finding care here in Grand Junction or in settings that I call restricted settings. So what are those? Restricted settings are settings where the health system, for whatever reason, of which there are several, decides that they're going to opt out, you've heard that phrase, opt out of participating in the End of Life Options Act. Sometimes that's for faith-based reasons, and I think you have that situation here in Grand Junction, where the whole hospital system says, nope, doesn't fit with our ethical and religious directives, and not only will you not do it, but any doctors associated, affiliated, employed will not do it. So that's a pretty big restricted situation, where due to a doctor's employment or affiliation, they're prohibited from doing medical aid and dying. The federally qualified health centers have similar restrictions, not based on faith-based issue, but based on the Assisted Suicide Act that I just talked about, because they get so much government dollars and they're kind of petrified. And then there are a few restricted settings where the health system just says, no, we're not going to do it, and prohibits their clinicians. So that's restricted health systems. You may be seeing a primary care specialist who's in one of those settings. The other situation we have to deal with is the clinician who says, well, I'm just not going to do it. I don't believe in it, or I don't know how to do it, or I don't want to do it, lots of different things. And this is where we hope our organization can be helpful. One of the things about COVID that has happened over the past few years, I'm sure you've all experienced this, is that the ability to have virtual appointments has expanded greatly, and we're doing much better with that. So, if you ask me what my first choice would be for patients and families, it would be being cared for by their own doctor and consultant. My second choice would be being cared for in person by someone in their community who they could see in person, at least for some of the visits. But there is another choice that we've been able to use, and I want you to know that that's available for folks in Grand Junction. If your care team can't or won't help you, or your family member, we do have options where this care can be done virtually by very qualified colleagues all over the state. And so I just want you to know about that, because sometimes some of the phone calls I get are very desperate and very anxious, like, there is no pharmacy here, or there is no doctor who will help me. And the first thing I like to do is say, we can help you. We can get you help. And so I want all of you to know that. I think that even the pharmacy situation, you might find it surprising that we can actually FedEx the medications. The first time I did this, I was like, whoa, it actually works very well. And so even if you say, well, there's no pharmacy where I live, that doesn't have to be a barrier to getting the care that you or your family member might want. So there's some hope in that regard. Part of our work at End of Life Options Colorado is to also help educate physicians. So I'm meeting with a group of physicians here in Grand Junction on Monday, because what we want is to make sure, just like with the public, that our physicians are well educated about the issue, that we don't have physicians telling patients things like, oh, it's illegal in Colorado, which we've had happen, or no, nobody in Grand Junction will do this for you, or other crazy things like that. We want our physicians to be well informed. We want them to be making their own choices about whether they're going to participate. And if they can't participate, we want them to be able to, in a professional and compassionate way, be able to refer. So that it doesn't get into this situation of you feel like you're being completely abandoned by your care team, which unfortunately many patients and families have. So that's a big part of our goal. Yeah.
You said you were an employed physician much of your career. We have 4 hospitals in the area. One of them is faith-based.
Right.
One of them is VA, so I'm assuming law avoids that. Doctors are certified in 1, 2, or 3 hospitals, or able to admit in 1, 2, or 3 hospitals. If they are able to admit in the faith-based hospital, but also a community hospital, can that keep them from participating?
That's a really good question. So as with my ethics mentor used to say, the answer to every ethics question is, it depends. Okay, so it depends on their employment, right? So not to go too deep into what happened some years ago with me, but if those physicians are employed at Intermountain, SCL, but they occasionally do work at community, it's probably a big problem, because it's who employs them. Now, if they're employed at community or in private practice, and they have privileges at Intermountain, but Intermountain's not paying them them, et cetera, then as long as they don't want to participate in medical aid and dying activities at St. Mary's, it's probably okay. But the policies are broad, and the policies that were written by then Centura in Metro Denver were very, very broad in terms of saying that no affiliated, associated, employed physician could do any of this anywhere. So that's why it's been a pretty big controversy. You're lucky, I would say, to have not all restricted settings here, because then you have some choice at least, I hope. And the group I'm meeting with, and we have invited some other doctors to that as well, and we'll see how that goes. That particular outpatient group has no prohibition against their physicians working with patients who are interested in medical aid and dying.
Can you feel comfortable telling us where it is? Because I'm going to call my physician.
I'm going to get it wrong. It's Primary Care Partners.
I know where it is.
Yeah, they have more than one location, right? I hope I show up at the right one on Monday, right? Okay. And, you know, the thing about a group like them, I don't know how many clinicians they have. They have quite a lot of doctors, I think, right? I think they have a very good reputation. I don't know. Yes, I see some head nodding. Is just remember what I just said before. They're not saying our doctors can't do this. So to me, I'm obviously very biased. Great. But that doesn't mean every doctor in their group is going to be able to help. But at least they're not creating this atmosphere. And in the best of worlds, in a group like that, to me, you'd have a few doctors who are able and willing, so that even if your doctor, for some reason, can or won't, you're still in your group. You know, you're still kind of in your medical home in that situation. So, yeah, absolutely. Advocacy. I just met with the Compassionate Choices, the big national group. There are some efforts in Colorado. I won't go over all the details to change some of the things that I just mentioned. So we're working to decrease the waiting time, so it's not 15 days, working to get nurse practitioners and eventually perhaps physician assistants as prescribers, and then eventually getting rid of the residency requirement as well. So, really, I think in summary you get it where I'm coming from. There are many, many choices. I started with that, and I like to end with it. We focused a lot on medical aid and dying today, but please, the takeaway is to think about what's important to you and your family and your quality of life, and understand that hopefully if you are faced with such a decision, that you know what your choices might be. Our statute isn't perfect. Our state isn't perfect. But we've got a lot of good things going on. And even though if you read it or listen to everything I said, you think, oh, this is too overwhelming, I could never do it, that's not the takeaway. The takeaway is we got to go through some steps, and we can do that to get you what you want, and to provide the opportunity for the kind of death that you might want. We do have barriers in Colorado, and we're really working on those to make sure that everyone in Colorado who qualifies can have access to a qualified physician if need be. Thank you so much. I think we're going to take just a little breather, get a little bit of water, and then we're going to have our panel come up, and I'll answer questions.